Okay, let's move to the last speaker of this session from Dr. Yejin Ann from Shuanghu University. Her topic is assessing deep brain stimulation efficacy in epilepsy, target accuracy, and thalamic pathology. Welcome.
Hello, I'm Yejin, and thank you for the opportunity to present my project. My project is about assessing the brain stimulation efficacy in epilepsy. I have no disclosures. To start, I will give a brief overview of the epilepsy and the brain stimulation. The epilepsy is the chronic disease involving recurrent seizures across the brain regions. And there are many subtypes of epilepsy, but it can be broadly divided into two main types, focal epilepsy and generalized epilepsy. Focal epilepsy can specify the origin of the seizure, but the generalized epilepsy cannot localize the seizure onset zone because the seizure originates from the multiple brain regions. And patients can receive the medication or resective surgery, but for those who are not suitable for either option, the neuromodulation treatment can be considered. The deep brain stimulation is the part of the neuromodulation treatment. It continuously stimulates the subcortical regions regardless of seizure onset. And the thalamus is the major target in epilepsy. Although it contains multiple nuclei, the anterior thalamic nucleus and central median nucleus are the primary targets in epilepsy patients. Because those nuclei are related to the thalamic circuit, Papez circuit is the major pathway of the limbic system, and the cerebellothalamic cortical circuit, it is associated with motor action and planning. And both circuits are involved in seizure propagation of focal epilepsy and generalized epilepsy patients that I mentioned on the first slide. So in this analysis, using those ATN and CM-DBS patients, we want to know about the predictive features of DBS outcome based on neuroimaging features. First, we will figure out the relationship between DBS surgical target accuracy and the DBS seizure outcome. And then we will identify the biological features related to the thalamus and the beyond thalamus in the network level that is connected to the rest of the brain. So using those features, we will predict the DBS outcome using a machine learning algorithm. We use the data from Samsung Medical Center in South Korea. We have two different patient groups, ATN group and CM groups. And both groups have heterogeneous types of epilepsy, but ATN groups have similar characteristics with focal epilepsy patients. Their seizure onset zone is located in anterior region, like frontal lobe and temporal lobe. But CM patients have similar features with generalized epilepsy patients. They have difficulty localizing the seizure onset zone. Before the main analysis, we need to find a best thalamic atlas that is well segmented and reflect the biological features of the thalamus. We use the postmortem histology map as a ground truth. And I manually segmented the nucleus based on the anatomical boundary. And then we compare the histology map with the existing 5 thalamic atlases. We compute the dice index between the ground truth and the atlas nucleus. The higher dice index represent the greater overlap between the ground truth and the atlas nucleus. The results show that the Thomas atlas and pre-Super atlas have the good performance in ATN and CM, so we use different atlas for the different nucleus. So using the selected atlas, we measure the DBS target accuracy by computing the dice index between the selected atlas and the DBS stimulated area estimated based on the electric field. And I generate the correlation between the dice index and the seizure reduction rate, that is the target accuracy DBS outcome. And the ATM patients show the significant positive relationship between dice index and seizure reduction, but not in CM. So then I constructed the ROC curve to classify the responder group and non-responder group using the dice index value. Only ATM patients show the significant good performance in classification. Then what about the CM group? Then we identify the biological features related to the thalamus by comparing the thalamic morphological differences between the average control thalamus and subject-specific thalamus to determine whether the thalamus is atrophy or hypertrophy using the shape analysis tool. We compute the group comparison between the responder group and control and non-responder group and control. This is result. ATN responder group shows severe thalamic atrophy compared to the control across the multiple nuclei. And also non-responder group show the atrophy but less than the responder group. Also the CM patients group show the similar result with the ATN group. The responder group show the severe thalamic atrophy compared to the control than in non-responder group. So in this analysis, we suggest that when the thalamus is more severe atrophy, then the stimulation could create a better DBS outcome because it may be related to the epileptogenic physiology. Then what are happening outside of the thalamus? To discover the network substrate, we trace the thalamic circuit and patient for the puppet circuit and CTC circuits for CM patients. We convert this tractography image into the track density image. It counts the number of tracks in each voxels. And using this TDI, we compute the group comparison derived from individual phenotyping. So we trace the circuits and individual phenotyping, and then we measure the mean Z-score value for each track within the circuit. And the positive mean Z-score represent the increased track density compared to the control. ATN responder group shows significantly increased track density value in 4 tracks, but only 2 tracks are significant in non-responder group. And in CM group, both responder group and non-responder group show significantly increased track density in both tracks, but the statistical power is greater in responder group than in non-responder group. So the increased track density was more pronounced in responder group than in non-responder group, and reducing the network connection related to the thalamus could suppress the seizure propagation. So we have analyzed the target accuracy, thalamic atrophy, and thalamic network. Using those features, we will classify the responder group and non-responder group using a machine learning algorithm. So we use these features and we train the support vector machine with a live-and-out cross-validation. The black line is the mean prediction accuracy of ATN and CM patients. in unimodal classification, the track density image have the best performance in classification. But in multimodal classification, all of the combination of features have the stable accuracy above the 0.7. So this is summary. Our study demonstrated DBS efficacy is influenced by both clinical and biological features. First, in clinically, the higher DBS target accuracy leads to the better DBS outcome in only 18 groups. But in biologically, the responder group shows severe thalamic pathological effects than the non-responder group in both ATN and CM group. And a combination of all three imaging-based features successfully classify the DBS outcome using a machine learning algorithm. Thank you for attention, and special thanks to my professor, Seokjun. Thank you.
Okay, thank you very much for your nice presentation. We do have a question from the audience. So, how can you validate the accuracy of manually segmented histology data?
As you can see, the histology map there, boundary is very clear. So I think it is reliable and anatomically accurate, but I think it is not enough. So we need to have another segmenter and conduct the inter-rater reliability.
Okay, thank you very much. So thank you everybody for joining this session, and we hope in the future together we can use brain stimulation methods to treat different brain disease and maybe understand better brain, and maybe using brain stimulation to enhance our intelligence. In the age of AIs, we can also enhance our intelligence using brain stimulation. Okay, thank you very much. Hope you enjoy your night. Bye-bye.